frailty score or clinical frailty score or CFS. And the guidelines suggest that if the frailty score is more than 5, please do not put these patients on the ventilator if you are suspecting COVID-19, because they are unlikely to recover because of their comorbidities. And if obviously their CFS or frailty score is less than 5, then they are for full escalation, and you do obviously give them every chance within your resources. So that is one thing I wanted to add. And then also in terms of compliance, as Dr. Temur has mentioned, that obviously in typical ARDS, you see that their compliance is reduced. But in these patients, initially when you put them on the ventilator, you find that their compliance may not be that much affected. But obviously, as the disease progresses, their compliance gets reduced. Compliance means, how much tidal volume you can generate for a given pressure. So that is something what obviously we are seeing is different from typical ARDS. And also from fluid balance, as Dr. Temur has kindly mentioned, just initially we were drying them out like mad. That obviously is giving them furosemide and not giving any fluid. But obviously, recent discussions, particularly from London, we had a webinar, couple of and information from that which was shared from different colleagues, that we may be drying them up too much. So be judicious and give due consideration that these patients may be pyrexial and they have significant insensible losses. So they are moving more towards even balance. So rather than getting them into negative balance, try to get them into even balance. But again, the jury is open. Obviously, we keep on learning about these patients. It's obviously first time we are experiencing this, so we'll have to keep our minds open. So
I have a couple of questions.
Hard and fast rule.
Dr. Hafiz, thank you. I've got three questions come up, and in fact, more are rolling down. Ikra Qureshi from Pakistan. She's asking, higher PEEP, does it also indicate fibrosis? This question to Dr. Temur. Take more questions. Can you limit yourself 30-second answers so we can go through very quickly? So the question from Ikra Qureshi, higher PEEP, does it indicate fibrosis? Quick answers, please.
It does, because this disease also involves, especially the coronavirus things, also involves the microvascular thrombosis inside the pulmonary capillary. And due to high oxygenation demand, the lungs are rapidly going into, somehow, we don't know the cause as yet, going into fibrosis. So high PEEP it's not necessarily, but can be indicated in fibrosis.
The next question is from Sabina Hashmi from UK. And Dr. Hafiz, it's question to you. Which fertility score you are using in your common practice?
I have been obviously following which is recommended by NICE. So if you just Google NICE guidelines COVID-19, it gives you the CFS or clinical frailty score. So if you just go through that, and it does obviously, there is a bit of user variability, but once you start using it, you will tend to agree that most people will be able to you can put them in certain categories and decide accordingly.
Thank you. This score we use is basically COVID-19, and we can Google it. And this is constantly updated as well, isn't it?
That is right. Obviously, the NICE guidelines, UK government is obviously keep on updating. But basically, the frailty does not necessarily changes, because obviously, when you are asking certain questions to the patient, what they can do before they became unwell with COVID, so we are looking at what they were like, say, before they became unwell, and this frailty score you based on that. So they are not. This frailty score is not based on how they are now, but how they were before they became unwell.
Absolutely.
So that will be their general physical health.
I have another question which I addressed Dr. Temur Mirza. Salman Nasir Baloch from Pakistan. He's asking, is there a specific pattern of arterial blood gases that we should be looking for in COVID-19 patients? Dr. Taimur, question to you.
Yeah, it is not that we should be looking for, but there is a pattern in which initially the PO2, arterial PO2 is low and CO2 is high. So with proning, we then tend to see the PO2 starts to build up because that is as it gets more surface area and CO2 starts falling down. But when we put them back on their backs, the pattern comes back as the low PO2 and again the CO2 starts climbing up. That's why the multiple proning and early proning is recommended in these patients.
Thank you. And Dr. Ajmal Khan from Pakistan again. Dr. Hafiz, this question goes to you. He's asking, could you explain peak airway pressure and mean airway pressure in the setting of pressure control ventilation? Dr. Hafiz.
Peak air pressure is obviously at the height of inspiration. The pressure you're getting is the peak airway pressure. I mean, this is a bit obviously complex, which obviously you can mean airway pressure is which is through obviously throughout the ventilatory process, and it's obviously the ventilator is giving you those figures, and but typically we will be looking at what is the mean airway pressure we are setting on.
And Dr. Taimur Hassan, this question goes to Dr. Taimur Mirza. Dr. Taimur Hassan from Pakistan asking, what is the rate of transfer of coronavirus in ICUs in England?
Well, because this is just in the beginning, we don't know as much, but the recommendation is that you set up the coronavirus patients separate ICUs. So we are not keeping mixed patients in any of the ICUs. We had initially had mixed patients because there are some patients who were corona negative, but they were showing exactly the same symptoms which the corona positive patients were showing. So the corona negative result was not indicative that the patient is not corona positive because they were all in fulminant ARDS, all requiring FiO2 of 100%, 80%, 90%, exactly the same pattern, but corona negative. So what we did was we moved those patients away into other hospitals where there were less corona, no corona patients, and we moved all corona patients to one. So basically keep the patients separate.
There's one more question from Abdul, Dr. Abdul from UK. Are you using any antiviral medications in ICU? Dr. Hafiz, you like to take this question?
Not as yet, and because obviously UK, we have not really gone on that line. So unless the patient is on a clinical trial, we are not giving any routine antiviral or hydroxychloroquine. So both these medications are specifically only if we find evidence that patient has got any other viral illness, we will not be using antiviral.
There's one more question from Dr. Aqsa Zahoor. Dr. Aqsa from Pakistan. In fact, before I go on to that, I want to take questions of Dr. Vikesh Kumar. Dr. Vikesh Kumar from Pakistan. Dr. Taimur, this question is directed to you by name. He's asking that excessive drying of patient, is it necessary? Do you want to use furosemide for that as kidney may get hit? What is your viewpoint on drying of patient? It's a very important question.
Yes, yes, it is absolutely important that we dry up the patient because there is no other means of how to get the extra fluid, which is because of the septic process has gone into the alveoli, how to get them out. It's inflammatory fluid basically, how to get them out. So one of the strategies, or rather only one strategy, is to dry the patients. We were, as Dr. Hafiz mentioned earlier on, that we were overzealously drying the patients, which the now discussions have come out that do not dry the patients overzealously, but still keep them negative. Once or twice use, because we were using furosemide quite regularly, like TDS or BD, 20 milligrams to 40 milligrams BD. But now what we are doing is that we just bring the patients to that edge, to the negative balance, and then try to maintain. So don't give extra IV fluids. There's no requirement. Just if your patient is being ventilated, just put the NG tube and keep them feeding NG feed. and they don't need any extra fluid. So just keep them on NG feed, no extra fluid. If they're still positive, use a little bit judicious use of furosemide is recommended, but don't over zealously dry the
So,
patient.
Doctor, coming back to Dr. Aksa Zahur's question, are there special considerations for weaning the COVID-19 patients off the ventilator? Dr. Hafiz, like to take this question?
Special considerations, obviously, when we see a patient is ready to be weaned from the ventilator or extubated, we would normally give a trial of extubation. But in these patients, we have concerns for other healthcare workers, and the advice is that possibly we should consider tracheostomies in these patients, and that we may be able to control the spread of aerosol better as in as opposed to doing a trial of extubation and then reintubating. So that is one area we are looking at. But having said that, as we say, it is early days in UK experience, but that is what being recommended.
There is one more. In fact, there is a flurry of questions. I'm seeing a long list of questions coming up. That shows the interaction people want to have with you, and you've touched the nerves of a very sensitive topic. Dr. Umar Sumro asking from Pakistan, saying, have you started testing healthcare workers for IG positive COVID-19 serology and promoting their placement in ICU? What a question. Wonderful. Dr. Tamur, your answer, please.
Right.
Not as yet.
Not as yet.
But
That's
yes,
a prompt answer. That's
you can
that's a
contribute.
good one. Dr. Tamur, you want to take this as well?
No, that's fine. I mean, his answer were
Not
not
as
as
yet.
yet.
So it's a sharp and quick answer. Rashid Riaz from UK, he's asking lab result leukopenia, lymphocytopenia, leukocytosis elevated, but does procalcitonin level more elevated in severe patients? What are your take on that, Dr. Hafiz? Is a procalcitonin level?
We in our unit, we do not measure procalcitonin, but I mean maybe in other units where they are obviously observing, uh, they would be able to advise on that. But we primarily look at the blood picture, and they would have lymphocytopenia. So, so that is very clearly shown that most of these patients, they will have lymphocytopenia along with hypoxemia. So that, and along with obviously the three features we typically look at: the X-ray picture, hypoxemia, and lymphocytopenia.
Thank you. There's one more question from Dr. Muhammad Bilal Tahir from Pakistan. He's saying, if a patient has lower blood pressure along with ARDS, shall we still keep the PEEP high, Dr. Taimur Mirza?
Yes, we keep the PEEP high, and we can treat the low blood pressure with inotropic agents like noradrenaline or other agents like this, but don't treat the blood pressure with fluids. So you can use noradrenaline. I know the patient will be dry, but it can help you by bringing the blood pressure up. So keep the patient dry and use noradrenaline.
There are a few more questions. I can't really ignore these questions. I have to go through all of them. Thank you for the enthusiasm, listeners. You have really shown a lot of interest. Let me take a few more questions. Kishore Kumar from UK. He's asking that the corona negative patients have corona positive results. Is that something you want to consider as well in your management? That there's a known effect that
Sorry,
the corona negative patients can have corona positive results. Does it mean that you shift every corona positive patient to ICU, or do you do something else to make sure they're actually corona positive?
To be fair, we have got in our hospital different areas that if we suspect a patient could be corona positive, even without the test, like typically if they are hypoxic and they have got lymphocytopenia and they've got X-ray picture, we do not necessarily wait for the blood test, the swab test to check that they are corona positive or not. We will treat them as on clinical picture. And mind you that the test itself has got sensitivity of about 60%, which means 40% of those who are negative could still be positive. And also depends on how good the technique is of checking the nasal or throat swabs. So, so basically, we treat them on the clinical picture rather than on the swab. And we have got different areas in the hospital. One is who are stable, but they are suspected positive, they go into that area. And then if they are confirmed positive, then we've got a different area. And then from then on, if they need ventilation or ITU support, then they're transferred to intensive care.
Wonderful. I'm going to have to ask you to limit your answers to 15 seconds because the questions are flowing and I want to take every one of them. One more question from Dr. Fazlullah from Pakistan. How long in average COVID-19 ARDS patients are kept on a ventilator? Dr. Taimur Mirza.
Very good question and very complicated. Reason is I'm not going to take more minute, but it is recommended that at least 2 to 3 weeks at least should be given to them. And if they are not showing any results, withdraw the treatment and let other patients come take the ventilator because the resources are not very much, we are restricted. So if 3 months, 3 weeks, if patient is not showing any improvement, then you have to think to withdraw the treatment.
This is quite sad situation where unfortunately the fact that we are short of resources. Dr. Shakil Puri, he is the president of Association of Pakistani Physician Surgeons. The webinar also belongs to APPS UK. He's asking a question. Can you share your thoughts on the difference in treatment or supportive therapy outcomes for different ethnic groups? Dr. Hafiz, can you briefly answer this question?
It's a bit early to say that of the outcome in different ethnic groups, whether they will be different or not. But what we have certainly observed in our intensive care, that we are admitting more patients from Pakistani or Bangladeshi origin as compared to white patients. I'm not sure whether units share the same experience or not. Having said that, in our area, the population percentage is not that high, but certainly the patients who are coming to intensive care, they are primarily at the moment Asian from Asian origin.
Thank you. There's one more question from, let me see. Let's take this question from Muhammad Aleem. The role of steroids in ARDS because of corona. Steroids, ARDS.
I would briefly say no. There is no role of steroids in corona. So please don't, it's not advisable to give steroids in that situation.
One more question from Ireland. Midet Eldrani. Do you anticoagulate COVID-19 patients as the rate of pulmonary embolism is high in these cases? Dr. Hafiz?
So far, it is not recommended. So we are not really routinely anticoagulating these patients.
And then I take up the question from Muhammad Bilal Tahir. What about the inspiration to expiration ratio? Should that be kept inverse as well?
If there is, as I mentioned in my slideshow, that if there is hypoxemia, then you can inverse the ratio. And if you are getting the CO2 increased, then you have to increase the ratio 1:3. You can inverse the ratio if there is a question of the body is not getting oxygenated. So increase the oxygenation, you can inverse the ratio, but you will have to paralyze the patient. So remember, you have to paralyze the patient to inverse the ratio.
And there's one more question from Abdullah from Pakistan. Can we use one ventilator for 4 to 7 patients at once after bringing change in it as it was circulating on the internet? That's interesting. Yeah, Dr. Hafiz, have you seen that?
I have seen those videos, but where people have obviously divided the ventilator and tried showing that they are ventilating different up to 7 bags. But in clinical practice, I have not seen anybody using that. So would be keen to see somewhere where actually some clinician is practicing that, but theoretically it may be possible.
Can I add just a little bit to
Please
it,
go on.
because I have myself seen all these films, videos circulating on WhatsApp. The thing is that they have got only one ventilator and there are 4 patients. So please note that their compliance will be different. So somebody will be having requiring a tidal volume of 400. Somebody will be from that 400. Somebody will be generating 600, 700 volume. How you are going to control the tidal volume of individual patients? So it's simply not possible on practical basis.
Because ventilation is not just pushing oxygen into the lungs; it's a complete system, and it's a extreme, I would say, non-compliance, and it can actually lead to complications. The questions are flowing like tap. I've got Dr. Fauzia Shahid asking, have you tried treating patients with plasma of patients who have recovered earlier? That's an interesting question, and I want to take both of you on that just briefly. Trying plasma of patients who have recovered. Do you want to take that?
As far as I know, it has been treated in Pakistan, but in United Kingdom, this is not a modality. We have not treated any patients from plasma.
Dr. Hafiz?
Theoretically, it is a possibility, but typically, I was reading somewhere in the literature that you need as many as up to 70 patients plasma to generate immunoglobulin for one patient. So I'm not so sure how practical that will be and how quickly that obviously treatment modality will be available. So
I've got a question from
pass on that.
Sri Lanka as well. Dr. Tilan Leangi has asked a question from Sri Lanka. What is the reason of sudden deterioration in oxygenation of corona patients? Is it due to lung fibrosis? Dr. Hafiz, can you answer this question, please?
I think what people think is more a coagulation problem rather than as it's microcoagulation in the alveoli rather than fibrosis at early stage. But the picture is similar to fibrosis.
Dr. Taimur, do you want to take on that as well? It's an important question.
No, I'm okay with what Dr. Rahman has said. It's what is the reason of sudden deterioration in oxygenation? Which question was it?
Why people suddenly deteriorate?
Fibrosis is a process, but basically it's basically with ARDS because it's a fluid-filled cavities which are leading, but eventually it leads to fibrosis.
Right. We will take 2 more questions before we close. It says there's one more question from Mahnur Nadeem, Pakistan. Is there a possibility that a patient can die from corona within 1 day? Have you seen that in your experience, Dr. Taimur, Dr. Hafiz? Just a quick answer. Patient brought in and dying the same day or next day.
Cardiac patients who are hypoxic, they can die. They can precipitate an MI, and there they go.
Dr. Hafiz, you share the view?
Yeah, definitely have existing comorbidities, then they can die very quickly.
There is one question which belongs to ethical side of things. Sayyid Ali Raza from Pakistan. End of life, when ventilator has not worked. Who is that going to be discussed with? Patients, relatives?
Well, it's basically a clinical decision.
Sorry, I didn't get the...
The question is that turning off the ventilator when things are not improving, but the patient is alive. Who's going to make the decision here?
The clinician. Basically, the clinician.
In practice, it is the clinician's decision, and we make that decision and share it with the family. But obviously, in Pakistan, my observation is that it is how clinicians approach that ask the family, do you want to take the ventilator off? Which, in my humble opinion, is very wrong approach. And I would encourage